The broadcast is now starting. All attendees are in listen-only mode.
I'd like to thank those of you who have joined us. This is the COVID-19 webinar, and we'll be starting in about 4 to 5 minutes. Okay, I think we'll hang on for a couple more minutes, and then we will get the webinar underway. Okay, I'd like to welcome you all to for joining us today at our fourth CAS Town Hall webinar. It's just after 1 o'clock, and so we'll get the webinar underway. And we do have a few people still joining us, but we'll do some of the introductions, and then they'll have time to join and we can get on with the discussions. I'll introduce myself. My name is Daniel Bainbridge, and I'm the president of the CAS. And we've got a great topic today. We're talking about COVID-19, diagnosis and management. And by management, we're going to look at respiratory support strategies, and we're also going to look at treatments. We have three really excellent guests. I'm really looking forward to these talks. We're going to start out, the first talk will be by Dr. Hoang, who is the Associate Director of the BC CDC, and she's also Associate Professor at the UBC Laboratory Pathology and Laboratory Medicine. In addition, we have Dr. Niall Ferguson and Dr. Granton, who are both professors. Dr. Ferguson is Head of Critical Care Medicine at UHN, working out of TGH. And Dr. John Granton is the head of the Division of Respirology. Both of them work in critical care. And we're going to have them speaking on ventilator strategies and some treatment options. So in order to get this going, I'm going to invite Dr. Hoang to start, and she's going to be talking to us about diagnosis of COVID-19.
Hi there, thanks for the opportunity. It's a great privilege for me to share some of the things that, as medical microbiologists, we're trained to do, and we look forward with a once-in-a-lifetime opportunity to serve as medical microbiologists. Just to clarify, I am not the Associate Director of the BC Centre for Disease Control. I'm sort of second in line within the Public Health Laboratory, which is part of the BC Centre for Disease Control. And I prepared what I'm calling a primer for anesthesiologists. So there's a lot of technical issues and components in the laboratory that aren't well shared with the general medical community. So this is an opportunity for me to share with you what we do in the laboratory and how this is important for your practice. So if I can. So this is a depiction of the coronavirus on the right-hand side here, showing the key proteins on the viruses. And this is really important in the design of assays in the laboratory. Knowing the genomic, the DNA sequences that compose the components of key proteins in the viruses allow us to be informed to design assays that have the optimal parameters for detection. And the targets that we look for are those that are required for for life of viruses. So those are things like polymerases and genes on the proteins that are key to their survival. And that's important because there is minimal chances of any mutations that will allow our assays to no longer be optimal. So a bit about the timeline of, in British Columbia, the evolution of our SARS-CoV-2 assay and how it was developed. So as you all know, towards mid-December, there were reports of an unknown pneumonia in Wuhan. By the end of December, WHO had declared that there was a pneumonia of unknown cause. The laboratory confirmation of a novel coronavirus in 40-some patients was reported in early January. And the key date here is January 10th, when the first genome of this novel coronavirus was published publicly by the Chinese government. And that allowed the international community to quickly get on to designing assays. So we had submitted our order for primers to target those key genes that I had showed on the last slide on January 13th. By January 14th, WHO, their team were doing the same thing, had reported their PCR assay, which we evaluated and compared against ours. And our evaluation started January 20th when the primers arrived. By January 23rd, we had the first person under investigation identified, returning traveler from Wuhan with fever that was submitted to the testing, and our first positive was detected on January 27th. And by February 2nd, we were testing more samples in British Columbia than the entire USA for various other reasons I won't go into today. So just to share with you all that in the design of all the assays globally, the majority of these assays were prepared without access to any live viruses. So in contrast to historical assays, and this is really from the laboratory perspective, very monumental in how rapidly we're able to generate assays strictly from the availability of publicly shared genomic information. So the next couple of things I want to talk about are the analytical performance and clinical performance of assays. And this is something that's really key in order to interpret and understand the results of assays. And so when we talk about the analytical performance, it's how the assay performs within the laboratory when we're evaluating it. So what is the test that we're talking about? What the test is, this is an RNA virus. We need to translate it to DNA and then amplify the DNA. And you've probably seen this in biology, microbiology 100 or biology 100, where you start out with a DNA copy that gets multiplied after one PCR cycle, multiplied again after a second PCR cycle, duplicated again, and so on and so forth. So each cycle of the PCR reaction, there's a doubling of the target DNA. And so by the fourth cycle, this is referred to as a CT of 4 or a cycle threshold of 4. And this is really important because it allows us to quantitate the amount of DNA in the sample. So if you start out with 1 copy and after 4 cycles, you end up with 16 copies. If you start out with 4 copies, it only takes 2 cycles to generate the same number of copies. And that reflects a larger starting number of DNA that's present in the sample. So in our sample, we target the RDRP gene as well as the E genes. Other assays have slightly different gene targets. The other important component is the internal sample control. And so this gives us an indication of whether patient samples are present within the submitted collection. So if it's a nasopharyngeal swab, are there any human DNA present in that sample, an indication of sample quality? And again, the number of cycles that passes at the point of threshold, that passes the threshold, is a quantification tool for us. Okay, a little bit of biochemistry and microbiology. So this curve here is very important. Again, it shows the number of cycles on the x-axis, and the fluorescence, which is a correlation of viral load on the y-axis. And this curve here shows the exponential increase of DNA during the PCR reaction. So for example, you have samples 1 to 5 generated on what a typical result would look like for us. You can see here that sample 1 intersects the cycle threshold at a CT of 23, sample 2, 26, and sample 4 at a CT 32. So what this means is that CT23 has a higher viral load because it reaches this threshold sooner than the sample 4 at a higher CT value. So the CT value is an inverse correlation to viral load. And why is this important? Because that is how we report our results. And so our assay, a positive result, requires a CT or a cycle threshold of less than 35, a negative result of greater than 40, and the in-between that is a challenge and a confusion for everybody. An indeterminate result is a range between 35 and 40. When we look at the analytical assay and the attributes that we design into the assay, our assay at BCDC and most homebrew RT-PCR assays have a limit of detection of less than 10 RNA copies per mil of sample. The majority of the commercial assays that are available have a limit of detection of about 100 RNA copies per mil of the sample. We try to align it with our workflow so that operationally it is easier to increase when necessary. And also the assay needs to be handled in a regular laboratory and not one of these high risk CL containment level 3 or containment level 4 laboratories. And the virus is considered a containment level 3 in pure culture. So our assay targets multiple genes, the RDRP, the E gene, and very importantly, the RNase P, which is the internal control that is an indicator of sample quality. We evaluated and validated our assay against nasopharyngeal samples, throat samples, and we're currently in the process of evaluating throat to nose samples. And all of these parameters contribute to what we refer to as the analytical sensitivity of our assay, which is at 100% sensitive and 100% specific. That means that when a sample should be negative, we're able to determine the absence of COVID virus, RNA virus in that sample. And if a sample is known to be positive, we are able to detect the COVID RNA in that sample. Okay, so how do we report that? So again, if the CT, the point at which the curve reaches the threshold of greater than 40 and the internal control is good, we report that as a negative result for COVID-19. If the CT is less than 35, and remember the inverse correlation between CT value and viral load, and the internal control is good, we report this as positive. That's a typo on my part. This is a report as positive for COVID-19. The indeterminate results seems to be challenging for many folks, and I'll try to go through that and introduce some clarity. First of all, the confusion comes to different laboratories using different terminology, and this is not standardized internationally. Some laboratories would use the term inconclusive, indeterminate, or undetermined. At our facility, we landed on indeterminate when a CT is not generated or is greater than 40, but the internal control is not generated. So this is an indication that there is insufficient sample presence in the submitted sample, and an indicator of poor sample quality. So probably the NP swab wasn't in the deep nares long enough, and there wasn't sufficient cells that were collected onto the head of the swab. However, if a CT value is between 35 and 40, and the internal control is good, there's multiple reasons for this. We do report it as indeterminate, but this could be an indicator of a low-level positive, either in early disease or late disease, and I'll get into more details of that. And the reason for this is because the RNA level of the virus is at the level of our assay detection. And so you can generate a stochastic result. Sometimes it's positive, other times it's negative. And so within this, what we call the gray zone, we would report this out as an indeterminate. The other possibility is sample contamination. So if on the assay in the laboratory where there is a very strong positive sample next to this sample that should be negative, you might have spillover of low-level amounts of DNA. And so that is a possibility. It is a real-life situation. We build in processes to rule this out after each run. This quality assurance should be evaluated. But as is life, things do fall through the cracks. Anyways, regardless, with the result of a CT between 35 and 40 and an internal control is good, we report as indeterminate possible low-level positive or contamination, recollect if clinically indicated. And that means if the result would change patient care management or public health action, then we would recommend that a sample be recollected. So this was a photograph taken on January 27th of our technologists, our core R&D team, who had developed the assay, done all the analytical testing, and ran and detected the first positive. So this is looking at the screen there, the PCR curve, which you probably can't see with this resolution, the PCR curve showing the first positive COVID case in BC. So some of the challenges that we face since the implementation of these assays and testing in response to COVID-19 is the swab shortages in the world. And this is primarily because there's a universal dependent on a company called Copan. Its factory is in northern Italy, and we're all aware of that part of the world being hard hit by COVID-19. And this is a picture here of the US Air Force with their chartered plane collecting over 1 million of these Copan swabs from northern Italy and flying it back to the US. And so we're in constant competition with international sources of supplies for swabs as well as reagents. And when we are able to get reagents, our recent batch, which came in from China, was heavily contaminated and not useful. And so nationally and provincially, there's been huge efforts in trying to stockpile swabs as well as all the various reagents required for the PCR testing. And it's been challenging due to the worldwide competition, lack of commercial flights, and border closures as a result of COVID. The other challenges we've been facing is the exponential increase in test volume, and this is across the country as well, where a laboratory, our laboratory had a capacity of about 200 tests per day and had to ramp up to meet the needs of testing about 1,500 samples a day. Initially, we were the only laboratory in BC doing the testing, and I had mentioned earlier, we were testing more people in BC than the entire United States by the end of February. And so we had to implement automation, bring in commercial systems with high throughput to minimize the burden and the reliance on our technologists. We also decentralized the testing to the hospital and the community laboratories. And due to the unreliability of reagents and swabs, we had to also implement multiple different assays as backup plans A, B, and C. And these, I'm sure, this approach is very familiar to anesthesiologists in the OR. So that's essentially a recap of what an analytical performance or some of the considerations and evaluations that we perform to generate an understanding of how our assay performs. The other component is referred to as the clinical assay, and the determinants of clinical assay performance depends on three key issues. There's other, but I think three very important and primary issues are the operator of the assay, which site is sampled, so whether we're sampling from the nose, the nares, the nasopharyngeal area, or the throat. And very importantly as well, and most clinicians don't think about this, is where in the course of illness we're actually sampling our patient. And I think this slide here is probably the most important take-home message that I'd like to share with you, is to consider the difference, or to recognize the difference between a clinical assay performance and analytical assay performance. And in the clinical assay performance, three very important issues are the operator's role, the site that's being sampled, and the time of the sampling, determining where the patient is during the course of sampling. And this slide here basically shows that whether you're dealing with throat or nasal, the result, the CT value, might vary depending on where the patient is at. So a bit about the operator. So is the operator using the right swab? There are a number of different swabs out there, each with its own potential contribution to the clinical performance. Was the test collected correctly? Was there sufficient sample on the swab? Was an NP done when it's required as opposed to a nasal swab? Could there have been a mix-up with another patient? And we certainly have seen that happening. Is the sample kept in the appropriate conditions? Was it kept at room temperature or at 4 degrees Celsius as opposed to at 25 degrees Celsius? Was the sample transported to the testing site within the acceptable time frame, and etc. So a number of key quality related issues that's very important that do affect the clinical performance of an assay. And we always like to use the term garbage in, garbage out. So poor sample submitted would result in a poor result. The second contributor to clinical performance is the site that is being tested. And in an infection where we don't understand the pathophysiology, this was very difficult. So I want to present here a landmark paper published by a group in Germany, in Berlin, the Charité group, that was the first group that really outlined the course of illness from a viral load and viral shedding perspective, and a comparison of different sites. So they followed 9 patients, and I won't go into the details here, but essentially 9 patients over time, and they've identified that both the nasopharyngeal and throat swabs, along with sputum samples, had good viral shedding over the course of the first week or so of illness onset. The other important thing is they also demonstrated viral load, so the viral replication within the nasopharyngeal samples, typically earlier on in the disease. And sputum samples, there was present of replication, so active replication towards the later components of the infection, particularly if there's a lower respiratory component. There was no evidence of replication in stool samples. There is evidence of RNA shedding, but no active live viruses detected. So they did some very nice studies looking at that. So those that are interested, you might want to have a look at the study. It answers a lot of the initial key determinants of the clinical performance. So to summarize Wolf's study, as well as a number of well-designed and well-reported studies, this slide outlines that live viruses are mostly likely shed during the first week of symptoms. So this is really important when deciding whether to test or not and how to interpret the results of the test. It's important to recognize that the RNA load is highest during the first week of illness onset and then decreases usually exponentially after that. The shedding, the RNA shedding, so this doesn't necessarily mean live viruses, but the presence of RNA occurs within the first 3 weeks and up to 37 weeks. And this has been a very challenging issue for clearance for infection control related purposes. And we don't really have enough information to say that at what point during these weeks of post-infectious shedding that is no longer significant or contributing to transmission. Folks have also shown that live viruses have been undetectable post 8 days post-symptom onset, despite the high viral load. And so this has contributed to guidelines and recommendations of when when a patient is symptomatic with COVID, that a 10-day duration should clear the presence of live viral shedding, particularly if the symptoms have resolved after the 8 days. Studies have also shown that nasopharyngeal swabs are more sensitive than throat swabs. And so when you collect a nasopharyngeal swab in parallel with a throat swab, they're generally equivalent, but there may be some fine details and differences. And some of those that are starting to arise include that in the earlier course of illness, the NP swab might be more sensitive, while towards later parts of the illness, particularly if there's a lower respiratory component, a throat swab might be preferable. Again, there are very few studies that have looked at these, and the numbers within the studies are relatively small. So we're still learning about the optimal sample types. The other piece that I think there's good evidence for, and that we're probably not utilizing nationally here, is the use of lower respiratory tract samples for diagnosis of patients who have a lower respiratory illness. And so we've had situations where an NP swab in a very sick person is negative, and the test is then deemed to be a poor test because it provides a negative result. However, when a sputum sample or a tracheal aspirate or a bronchial sample is tested for COVID by PCR, it was certainly positive. And so it's really key to recognize that where the patient is in the course of illness, the type of illness the person has should inform the best and the optimal sample that needs to be tested. There's also the component of asymptomatic shedding. Again, there's very limited data here, but one would imagine that shedding begins before illness onset. And I'll show you some graphs that might show you that. And we certainly have identified numerous patients who are totally asymptomatic but have presence of RNA. There are no studies that show viral active live viruses in asymptomatic individuals, but again, those studies have not been done. So the third component is the time of sampling during the course of illness. And again, upper respiratory tract viral load is the highest in the first 5 days, while the lower respiratory tract likely starts later and extends for longer with lung involvement. This is a nice pictorial, and I've removed the days at the bottom because it's, depending on the study that's being done, it's somewhat variable. But imagine that the infection begins on the far left here of the graph with an incubation period of up to 2 weeks. Symptom onset occurs within a week or so following exposure and infection. And one can imagine that the titer of the virus begins to increase a few days prior to symptom onset and peaks shortly and within the first week or so following symptom onset, and then a gradual decline after that. Let's not worry about the IgM and IgG on the right. We'll get to those later. So imagine a sample collected at this part of the graph might likely result in a false negative, a so-called false negative. And particularly if the patient is still asymptomatic. A sample collected at this part from days post-symptom onset may pick up a positive result, but again, you can see here that it is unnecessarily reflection of the peak of the viral load as well. And finally, if a sample is collected, say 10 or so days, 13, 14 days post-illness onset, it is likely to be negative. So many people, many physicians call us and ask us, well, why can't you tell us what the sensitivity of the test is? And what about the 30% that's been reported, 30% false negative that's been reported in the literature? So in order for us to determine the clinical performance, we need to be able to identify a gold standard for COVID-19 disease, presence of disease and absence of disease. And that doesn't really exist. There are a number of studies which I've referenced here, 3 studies that were published from groups in China use CT chest as the gold standard and compared the PCR assay against their defined gold standard. And you can imagine that this is really not ideal. This is where the 30% false negative PCR assay performance came from. And many people quote this as the challenge of our PCR assay. But I think I'd like to point out here that these studies are flawed and the true performance of an assay is dependent on multiple factors. So you can't talk about performance without doing some calculation. I don't want to get into a lot of details here, but again, the challenge with COVID-19 is that we don't have the gold standard definition of a positive disease or negative disease. We're not able to identify truly what a sick population is or a healthy population. Let's say a sensitivity of our assay is at 70% with a specificity of 95%. The other component that contributes to this is disease prevalence. And so that informs the positive predictive value or the likeliness that a positive result is a real positive and reflects disease, in this case at 93%, and a negative predictive value would be of 76%. But let's say we change that sensitivity and specificity to something like 95% and 98% respectively. And let's say that the assay that we have is a fantastic assay, and these parameters are really fantastic. Well, what would that look dependent on the various disease prevalence? So I've done the calculation, from a 70% prevalence down to 1% prevalence, and you can see how that changes the positive predictive value and negative predictive value. And so before we decide how and when to use the assay, and keeping in mind all the other components that contribute to clinical assay performance, it's important to look at the disease prevalence to inform how and when to deploy certain tests and how to interpret those results. And so for a very good assay with a 1% disease prevalence, a negative result would be reliably negative. However, a positive result might not be a true reflection of a positive, of positive disease. But again, keeping in mind that there's the other components as well that contribute to this. So to summarize the issue around clinical performance of an assay, we need to understand that multiple factors affect interpretation of results. So was the sample handled properly? Were there any errors in handling and testing? What type of sample was collected? Where was the patient in the course of illness when the sample was collected? And then finally, what is the prevalence of disease of the patient's population at the time of collection? Okay, so moving away from PCR tests, which is a test to detect the presence of viral RNA in a clinical sample. As you've seen in the news, and I'm sure there's a lot of discussion around the blood test. And what is the blood test? The blood test, also known as the serology test, is there to evaluate the immune response to the COVID infection. And so we're not looking for the presence of viruses as is for PCR. We're looking at the immune response to the infection that occurs in the host. And with any serological assay, they're extremely challenging. One of the reasons why diagnosis of Lyme disease is so challenging is because of the nature of serological IgG, IgM, IgA assays. So not to go into too much detail, but currently there are huge efforts nationwide dedicated into evaluating the performance of different types of antibody-based testing and different commercial products that are currently available. And so our tasks are to identify the best performing assays and also to make sure that there are supply chain availability and secured, not only for our province in British Columbia, but for all provinces across the country. And so that's where our efforts are put in place to address just that. And so how does the use of serology with the understanding of where the patient is at in the course of illness, how should we apply that? And so serology usually rises about 2 weeks after illness onset, as depicted by this graph here. It is not a tool for acute disease diagnosis. The PCR test is the tool for disease diagnosis, whereas the serology is used essentially to determine seroprevalence in an individual or within a population. So determine whether a person has seen the disease before, and for a population to assess the disease prevalence. And again, the same issues and rationale applies as discussed before. Where and when you collect the sample for serological testing is also very important. And so collecting it early on may not provide a highly interpretable result, whereas collecting a sample later in the course of illness is more likely to generate a reliable result. And again, it has nothing to do with the assay itself. It really reflects where the patient is in the course of the illness. So the ability to detect COVID-19 is a foundational component of Canada's containment and mitigation strategy, as well as in other countries. So while we're in mitigation, testing was used to determine population-based surveillance, as well as case detection and transmission prevention. Now that we're in containment mode, testing is essentially prioritized and dedicated to identifying COVID-positive patients amongst hospitalized patients, and as well as those with severe respiratory or flu-like illnesses, symptomatic healthcare workers, and also where testing modifies patient management, particularly from an infection control perspective, diagnosis and treatment plan. Very importantly, testing is also used for outbreak detection and outbreak management, and this includes outbreaks in acute care facility involving healthcare workers and patients. And finally, surveillance is a very important role with the data generated from testing. So as testing evolves and the criteria for testing evolves from mitigation to containment, these criteria then potentially informs the value in surveillance, and I'll get back into that in a bit. But just to point out here that recently in British Columbia, there's been another change in testing criteria, and that is approval of preoperative screening at the discretion of surgeons and anesthesiologists. And I can tell you this was not an easy win. This was a huge, significant effort balancing the limited resources from the diagnostic perspective, the infection prevention and control measures that are in place to protect healthcare workers, and also the post-op IPAC management issues. So balancing all that, the decision in BC was, well, this is an important criteria for at the discretion of the surgeons and anesthesiologists to identify when to test their patients for COVID. And so the key area for testing is really in patients with compromised cardiopulmonary systems, where if there is a positive result and the procedure is not a life and limb dependent procedure, there is an opportunity for the patient to run through the course of illness and have the procedure rescheduled until resolution of the disease. To have to recover from surgery along with dealing with the burden of disease could be traumatic for the patient. Where things are challenging and controversial is the role of asymptomatic versus symptomatic testing. And so one of the graphs that I showed you earlier, if a patient is asymptomatic and a test is negative, there is little confidence that that negative is a true negative. And so what are you going to do with that information, and does that change management and practice? And I think that's a really important consideration in deciding whether or not to test somebody. If an individual is symptomatic, they are likely at the peak of viral shedding, and a negative result there is likely to reflect true negative unless the person has a lower respiratory illness and the nasopharyngeal swab that you collected is negative because there's no active replication in the nasopharyngeal area, but active replication in the lungs, and so a sputum or a tracheal aspirate is probably preferable. Testing can inform post-op IPAC management. So if you know that a patient is COVID positive, let's send them right to the cohort COVID cohort in the acute care facility immediately, as opposed to having them in the general wards. So again, some of the limitations of preoperative screening is turnaround time. So if you don't have a laboratory on site, if the turnaround time is weeks, then the value of having that test is very limited. If the patient is in a life and limb situation where testing doesn't change practices, immediate practices, then it may not necessarily be required to test immediately, and that could be done post-operative. And then also recognizing that a negative test does not rule out disease for so many factors that I've mentioned earlier. So testing criteria.
Sorry, Dr. Hoang, we're running a bit long on time. Could you just wrap it up in the next couple of minutes? Thank you.
Yeah, got 2 more slides left. So testing criteria has been variable. Recognizing the role of the test and the criteria will help interpret some of these curves. And it, again, mentioned earlier, we've modified our testing criteria as well. So when interpreting epidemiological data, identifying criteria that has not changed. And in Canada is critical care. And you can see here in BC and similar data across the country, critical care numbers are a reliable indicator for epidemiological surveillances. And just the last slide to show that modeling is helpful to using the data that we have, but again, modelers are struggling with the constant changes in criteria to inform next steps. So what's next? We'll continue to evaluate the role of targeted PCR and serology for patient care, infection control, and public health response. Decentralizing testing, improve turnaround time. Key challenges are ensuring supply and ensuring laboratory environment, as well as healthcare workers and frontline folks. Automation where this possible, and then we're evaluating the role of genomics to inform next steps. And over to you for questions.
Thank you. I think we'll save, I had a few questions here. I think we'll save a few of those to the end. Just in the interest of time, I'll ask Dr. Ferguson to pull up his presentation and start. Thank you.
Okay, thank you very much. And I'm gonna just go into full screen mode here. Perfect. So thanks again for the invitation to speak. I'd like to talk about mechanical ventilation strategies for COVID-19 and patients who have severe respiratory failure related to that. A couple of disclosures, that's nothing directly related to this talk. So here's a typical ARDS patient, not necessarily with COVID-19. And we've learned over the years that what we used to think of as diffuse disease, when we started CT scanning people, I'll remind you that it's quite heterogeneous disease, even in patients with severe ARDS like this, with some areas of the lung, and usually in the dependent regions, which are collapsed, atelectatic, and other regions of the lung, often in the non-dependent regions, that are still gas-filled, and while not necessarily completely normal, this is the so-called baby lung that's receiving the bulk of the ventilation. And 25 or 30 years of translational research from bench to bedside and back again has shown us that ventilator-induced lung injury can occur if we're not extremely careful about how we're treating these fragile lungs. And this can be the driver of multi-organ dysfunction, because ventilator-induced lung injury obviously starts in the lung, but this can create an inflammatory process which spills over into the systemic circulation and brings on multi-system organ failure. And this is not just a disease of Sprague Dawley rats or New Zealand white rabbits. This really affects adults with ARDS, children too. And this is the seminal ARDS network paper published almost 20 years ago now, showing that simply by turning down the tidal volume and paying attention to the plateau pressure as well, they were able to reduce mortality from 40 to 31% on almost 25% relative risk reduction. Now, there are some patients, those with particularly severe disease, where even that may not stop all of the ventilator-induced lung injury. Patients with, that you can see here on the right-hand panel, with the smallest baby lungs, when they go from expiration to inspiration, you're still seeing a lot of red showing up there, which in this graph is indicative of overdistension, despite using 6 mils per kilogram. And this helps us understand the concept of driving pressure. So we know that taking care of tidal volume is important, but if you look at the driving pressure, which is the distending pressure across the respiratory system, so the plateau pressure minus PEEP, there's a clear association with mortality that is independent of PEEP here. So fundamentals here are so far taking care of tidal volume, focusing on driving pressure and trying to keep it less than 15. And another key area of investigation over the years is that it's been well documented that when you put patients with severe ARDS onto their stomachs and ventilate them keeping them in the prone position for 16 to 18 hours a day, that recruits basal lung units, spreads pleural pressures more homogeneously across the lung, and actually also results in significant reductions in mortality. So that's what we know already through 20 or 30 years of ARDS research. And so suddenly COVID-19 comes along in 2020, and everybody has lost their mind on Twitter and on YouTube, saying we don't know how to ventilate these patients, and every week we're seeming to hear new recommendations. Everybody needs high PEEP. No, nobody needs a ventilator. And I'm going to focus on a couple of high-profile pieces that have generated a lot of discussion. One that you may have seen from Luciano Gattinoni and colleagues, published in intensive care medicine recently, and they point out that there's a lot of heterogeneity in these patients. So here's 2 patients who are quite hypoxemic, and they have very different looking CT scans. This one on the right here, which they term as a type H patient, high amounts of collapsed lung and a small baby lung, looks what we're more typically used to seeing with severe ARDS prototypically. But this patient on the left here does not have a lot of collapsed lung, but does have a lot of hypoxemia, which suggests that there's vascular component going on here with potentially loss of hypoxic pulmonary vasoconstriction and functional intrapulmonary shunting. We've also seen editorials written by Martin Tobin, one of the sort of godfathers of ventilation, editor of the textbook of mechanical ventilation, who in this editorial sort of says some very sensible physiologic things, like you don't need to intubate somebody just because their respiratory rate is high. You should intubate them because they have high work of breathing or they're extremely hypoxemic. But these kind of messages often have been taken out of context, and we've seen them in the CBC. Ventilators being overused, says world-renowned critical care specialist Luciano Gattinoni, although that's not actually what he said. In the New York Times, we're moving away from ventilators because ventilators are killing patients. So I want to say that actually I want to recognize that COVID-19 is a new disease. It's a different, sometimes a different phenotype than what we had before. But I think it's important to recognize that ARDS is a syndrome. That's always been heterogeneous. And we've seen ARDS, we've known that ARDS patients can have lots of intravascular clots seen on autopsy for 30 or 40 years. We've known that some of them are recruitable and some are not recruitable. So I think my overall take is that we just need to refocus on on the physiological principles of safe mechanical ventilation, and that'll help us apply this to this new group of patients, some of whom have a slightly different looking phenotype. So I'm going to focus on two aspects for the rest of the talk. One is what's the right amount of PEEP, and the other is when should we allow these patients to be spontaneously breathing. So spontaneous debates about what the right amount of PEEP has existed as long as ARDS has existed. This is the everything we learned about ARDS. We learned in 1967 with the publication of the initial case series from Ashbaugh and Petty and colleagues. Ventilators were just new at this time, and they found a button that they didn't really know what to do with on the ventilator called expiratory retard, aka PEEP. And they noticed when they put that up, significant improvements in oxygenation. Also, this classic paper from Peter Suter and Barry Fairley showing that PEEP, when you're setting the right PEEP, it's important to consider both the respiratory effects and the cardiovascular effects. And they found actually many patients, these both went together at the same time. How do we set PEEP usually? In the large international observational study LungSafe, across 10,000 patients in 350 countries, you can see here that in all patients, the average PEEP was 8.4, and there was a slight gradient when you went from mild, moderate to severe ARDS. But even in severe ARDS, the average PEEP setting was 10. I think it's important to keep this kind of schematic in your head when you're thinking about lung protective ventilation. We want to avoid, for sure, this is the volume pressure curve of the lung, inspiration and expiration, with a fair amount of hysteresis in this example. We want to avoid this zone of overdistension, which we know causes ventilator-induced lung injury. And setting the right PEEP helps us, it's depicted here largely avoiding a zone of derecruitment and atelectasis, but the truth is these two things are tied together. The more derecruitment and atelectasis we have here, the more the remaining lung is at risk of overdistension because it's fewer alveoli having to accept whatever tidal volume you're giving. So how to set PEEP? There's lots of different ways to do it. In the setting of one of the most common ways that we see used in North America is through the use of a PEEP FiO2 table. And this was used, for example, in that ARSNet study I showed you earlier, where according to a different, if you're on 80% oxygen, that would indicate, oh, more severe disease, maybe you need higher PEEP. You put the PEEP at 14 and you hope to move to the left as you, if you get a good response to PEEP. We've also seen higher PEEP FiO2 tables tested. This one is from the lung open ventilation study that Maureen Mead and Tom Stewart led. And here you can see that around even at relatively moderate levels of oxygen, FiO2s of 40 to 50%, you could be up to as high as 18 to 20 centimeters of water PEEP. The response to PEEP is heterogeneous. And this is shown here because 3 large studies all showed no significant difference in mortality. When they were pooled together in an individual patient data meta-analysis, though, we see significant heterogeneity of treatment effect just by severity of baseline hypoxemia. So patients with what we'd now call moderate to severe ARDS, PF ratio less than 200, significant signal for improving mortality in the higher PEEP FiO2 tables, whereas patients with mild ARDS, PF ratio 200 to 300, not quite statistically significant, but if anything, the signal is in the opposite direction. And this gets back to the idea of tailoring your PEEP to the amount of recruitable lung that you have. And this is not a new concept. This is another paper from Luciano Gattinoni. Note the date, 2006 in the New England Journal. And they took people to this, they took consecutive patients with ARDS to the CT scanner and saw what happened to their lungs on 5 centimeters of water and at 45 centimeters of water as a sustained inflation recruitment maneuver. And some of them had good amounts of recruitment as shown here when we go from 5 to 45, lots of lung opening up. Some of them were poorly recruitable and didn't have that much collapsed lung to start off with. And this is one of the key points here. Most people who were not recruitable they didn't have x-rays or CT scans like this and were not recruitable. They weren't recruitable because their lungs were already open. And when you apply high levels of PEEP to lungs that are already open, all you end up doing is distending or over-distending the lungs that are open already. And note the cardiovascular effects here. The heart is being smushed by this high pressure that's all being transmitted to the into the pericardium and decreasing venous return. So normally we like to think about setting PEEP to patients, higher PEEP to patients who are more recruitable. And there's this study, again from Granton's group, investigated 4 different ways of setting PEEP. The only one that led to patients being more recruitable, getting higher levels of PEEP, was the PEEP FiO2 table. It's also important to note that, again, this heterogeneity of treatment effect is not a new concept. Carolyn Calfee and colleagues examined a whole range of biomarkers and inflammatory markers in patients who were randomized into these early ARDS network ventilation trials and came up with 2 distinct phenotypes. One more inflammatory with higher levels of IL-6, IL-8, and TNF, and one in blue here, which was relatively non-inflammatory. So that's fine, interesting into a sense. What's really interesting is that they had a different response to PEEP. So patients who were the non-inflammatory group had significantly higher mortality when you gave them higher PEEP, and in contrast, patients in the inflammatory group, although there were fewer of them, had a significant reduction in mortality. So who you apply PEEP to has a higher PEEP to has an important effect. One way to judge this is simply by looking at their oxygenation response to PEEP. And in this study, you and Gallagher looked at the first change of PEEP in patients going on to this lung open ventilation study, or the EXPRESS trial, and patients whose PEEP went up at the time of randomization, who subsequently had an improvement in their PF ratio, had a significantly lower risk of mortality, whereas when PEEP went up and oxygenation got worse, their mortality was significantly higher, whereas we didn't see any effect when the PEEP was the same or lower. And finally, I want to just highlight a new way that we recently published on trying to quantify exactly how much a patient's lungs might be recruitable. This is using something called the recruitment to inflation ratio that Lu Chen and Laurent Brochard have developed at St. Mike's and published recently in the Blue Journal. And this essentially works by dropping the PEEP from 15 to 5 and looking at the change in tidal volume associated with that, and making a ratio of how much of that change is simply due to a reduction in pressure and how much of that is due to de-recruitment. That can give you a measure of how recruitable somebody is, and with the idea being to use this at the bedside to say, oh, somebody's higher recruitable, I'll try going up higher PEEP. Point out this handy website. Anybody who's interested can go on here, rtmaven.com, developed by Tom Perreno, one of our RT colleagues in Toronto, which has an automatic calculator for this and lots of other interesting respiratory mechanics. This has actually been applied in patients with COVID-19 in a small group in China, and there were some patients who were not prone, treated in the supine position the whole time, and you can see that most of them are actually not very recruitable. The RI less than 0.5 was the median range in the original study, and so this we think means not very recruitable. And in patients who were undergoing prone positioning, no, some of them actually were significantly more recruitable. So switching gears in the last 5 or 7 minutes or so to talk about spontaneous breathing in ARDS. It's an ongoing subject for debate in all patients, but also applies to our patients with COVID-19, some of whom seem to have a very strong drive to breathe. And questions exist like when to allow it, how much spontaneous breathing to allow, And if we're considering targeting normal efforts, that also implies that we actually need to measure patient effort. And this revolves around one of the main concepts here is the idea that ventilation induced lung injury is as important as ventilator-induced lung injury. And so patients themselves may be driving some of this, where given initial lung injury from viral pneumonia or from whatever cause, which causes some lung injury and some lung edema and impaired mechanics and increases the respiratory drive, which then gives higher distending pressures across the lung, maybe causes some pendeluft and further overstretches the lung, which then worsens capillary leak and so on, and you get into a vicious circle about this. And this is the idea, again, if you read this paper closely, what Gattinoni is hypothesizing, because it's an editorial and it's relatively data free. It's more a supposition or a hypothesis that many patients present early on with this form of COVID-19, which may just be viral pneumonia or mild ARDS, although the oxygenation is worse than usual. And then some of them then go on to develop this phenotype, perhaps through patient self-inflicted lung injury because of high respiratory efforts. This old animal study proves that you don't need a ventilator to cause lung injury. This group inserted salicylate into the foramen magnum, made sheep hyperventilate like crazy, and that led to significant severe lesions on lung pathology, although there were no ventilators connected to anything here. And we've also appreciated recently that when patients have injured lungs, a phenomenon of pendeluft can occur because of differences, regional differences of compliance and where effort is being generated. What looks like a safe tidal volume might in fact still be injurious because it's all going to one part of the lung first and then moving to another part of the lung second, in effect doubling the stretch for any individual alveolus. So there's pros and cons of spontaneous breathing in ARDS. On the pro side, we might prevent diaphragm atrophy, maybe improve hemodynamics by having less positive pressure in the chest. Patients may need to have less sedation and its associated adverse effects. And you sort of feel like you're making progress towards patients liberating from the ventilator. The downsides potentially, though, are direct overdistension injury from patients taking bigger breaths than you want, this pendeluft injury that I just mentioned. We also may see increased lung perfusion, which may cause more interstitial edema and lung injury. When you start letting patients breathe spontaneously, then you have to worry about ventilator synchrony, and dysynchrony, particularly double triggering, can also cause injury. And all of these things may be made worse by effect modifiers of the severity of ARDS, the smaller the size of the baby lung, the higher the drive that the patient has, and the more injurious the baseline settings of the ventilator are. All of these things making it sort of tipping the balance towards spontaneously breathing in ARDS being even worse. So if we're talking about the size of effort, that means we have to figure out how to measure that. And I'll just remind you that the sort of gold standard for measuring effort would be the pressure time product across the diaphragm that we would measure with an esophageal balloon. That's possible to do, and we do put balloons in not infrequently in our unit. But even simpler is that you can estimate effort with a couple of non-invasive maneuvers. One would be to measure the P.1. It's a nice paper from one of our fellows, Irene Tellius. The P.1 measures the pressure that's developed in the first 100 milliseconds or tenth of a second during a expiratory occlusion maneuver, and it's nicely correlated with patient effort as measured by patient pressure time product. And if you're looking to rule in or rule out high or low effort, it has reasonable operating characteristics. So if the P.1 is less than 1, you can be pretty confident that the patient is being over-supported. Whereas if the P.1 is above 4.5, you can be fairly confident that they really are making high efforts to breathe. You can also measure this directly by doing an expiratory occlusion maneuver, and not just for a tenth of a second, but seeing how much negative pressure the patient's able to generate. Most ventilators can do this either as a stealth negative inspiratory force maneuver. This gives you the occlusion pressure, and that allows you then to multiply that by a correction factor to get your predicted amount of muscular effort that the patient's making, where a normal would be something in the 5 to 10 range. Just to point out that this is the double triggering that we can sometimes see if patients are making large efforts and are still trying to take a breath in after we've cycled to expiration. In this particular example here, this is shown as a larger tidal volume. In some ventilators, actually, you have to look at these tracings because the ventilator might count this as a second breath and say, oh, as soon as flow went to 0 here, that was the end of this breath, and this is a new breath, even though the patient actually hasn't had a chance to breathe out. So to wrap up, what should we actually do? We're seeing COVID-19 patients present in both of these phenotypes. In this phenotype, with the wet and white lung, severe ARDS, and sort of stereotypically classic severe ARDS, I set the tidal volume to be 6 mils per kilogram or lower to keep a plateau pressure less than 30 and targeting a driving pressure of less than 15. If the patients need to be sedated and paralyzed to achieve that, then so be it. And here, I think it makes sense to try higher PEEP, although each patient is their own physiological experiment, and you might try measuring recruitability directly. In these type of patients who have more hypoxemia than their chest X-ray might suggest, their lung compliance is usually not severely impaired. I set the tidal volume to be 6, maybe up to 8 mils per kilogram. I would tolerate larger spontaneous breaths as long as the patient was not making extreme efforts. And here I would start with a lower PEEP and sort of starting at PEEP of 10 and potentially titrating up or down from there depending on oxygenation response. So I've tried to show you that the COVID-19 ARDS is like ARDS, it's heterogeneous. We should try to tailor PEEP according to recruitability. The impact of spontaneous breathing depends on ARDS timing and severity. Measuring patient effort we think is important. And when you're allowing spontaneous breathing, you may consider normalizing efforts, but keeping in mind that we're wanting to protect both the lung and the diaphragm. And with that, I will stop and thank you for your attention and be happy to take questions.
Thanks. Again, in the interest of time, we're just going to ask Dr. Granton to present on medical management. And I'm hoping we have 5 minutes or 10 minutes at the end because we've got a couple of good questions to ask the panelists. Dr. Granton, thank you.
Great. And again, thank you very much, Dan, for inviting me to come today. And great first talks. Difficult act to follow, but I'll try my best. So I've been charged with talking about clinical trials during COVID or therapies for treatment for COVID. I could actually stop right now because there are none, and I can take questions, or I could keep going. And I think we've got a few minutes, so I'll keep going for the time being. So my goals really are fourfold. One, what have we learned from past pandemics in the context of sorting out therapies that either do or don't work? Have we learned anything? What are some of the challenges in conducting clinical trials during a pandemic? And we certainly see that to some extent in our own place, but we recognize there are hotter spots across the country which are resource challenged, making conduct of clinical trials very challenging. Talk a little bit about clinical trials underway, what's been evaluated, what's in the press, what works, what doesn't work. And talk a little bit about perhaps stemming from lessons learned, trial design during a pandemic, and some of the initiatives that are ongoing globally and to some extent regionally in our own centers. By way of disclosure, I have none as it relates to this talk. So as we know, in Canada and like other countries, there's a significant and fortunately more linear than exponential rise in cases across the country. And in some provinces, we're seeing some leveling off. And I think in our intensive care units, we're certainly seeing leveling off, at least in our own place in Ontario and certainly in other provinces, happily a downturn perhaps. But equally, what we're also seeing is the number of reported COVID clinical trials, and we've gotten to the point probably where there are more clinical trials, or certainly ideas, than there are COVID patients in this country perhaps. And if you go to clinicaltrials.gov, which is one of the registries, there's a couple others, but we'll use clinicaltrials.gov. There's over 600 trials which are currently registered to evaluate COVID-19. Now, one of the challenges really is relates to exactly what it is you're trying to study. And I think each of us has a different perspective on the entire problem, and it's like the blind man examining an elephant. We each have our biases, and we're feeling this infection from different corners and coming with our own expertise and biases and theories and trying to approach this problem. And the best thing about, of course, the internet and everything else is that there's a lot of really smart people working together trying to sort this out. The biggest downfall, however, is that there's a lot of really smart people working together trying to sort this out, which is proving to be somewhat of a problem in prioritizing clinical trials and approaches. We recognize that there are many approaches, some of them being directed towards the virus and preventive strategies and vaccines, which are ways off, prophylactic strategies, early versus late infection, looking at the consequences of infection, looking at anti-inflammatory therapies. We recognize that there are evidence of thrombosis in these patients, and there's some talk about using anticoagulants. We know that there are higher incidents of myocardial infarction and strokes. We certainly see a high prevalence of perhaps venous thromboembolic disease, as well as clinically clotting off of lines, and so there's interest in looking at anticoagulants. Antimicrobial treatments, not really azithromycin, but certainly other treatments, either empiric antimicrobial therapy or certainly directed towards pathogens which seem to occur as a secondary infection. We're seeing a very high rate of secondary infections in our patients, particularly things like Staph aureus, but a lot of bloodstream infections of stranger organisms that we would normally see in a patient who's been in the ICU for a prolonged period of time, who has other comorbidities. And then certainly, as Niall talked about, the lung, and certainly are there organ-specific clinical trials which are being considered. And we recognize from, this is a nicely conducted trial, or at least observational study of a cohort of patients out of Italy by some respected colleagues. And there are larger ones out there, but this is one that I've chosen and illustrates perhaps the heterogeneity of these patients that Niall alluded to, and recognizing that some of them present mainly with predominant respiratory failure, which there seems to be different phenotypes. But we also recognize that there are cardiac consequences of this condition and targeted therapies towards either investigating or treating the cardiac consequences. We also recognize that there are inflammatory consequences. People talk about this so-called cytokine storm, and there's a lot of interest in preventing that cytokine storm by immune modulating therapies. And there's even discussions about hemophagocytic-like syndromes with elevations in ferritin, D-dimers, and other things suggesting that therapies directed towards HLH may also be efficacious. And so it really depends how you approach this problem. And as a result, it becomes quite complicated, particularly when we're all trying to tackle the same problem, and enlisting patients in more than one trial at any given time does present logistic and even ethical concerns. So this leads to a discussion about the challenges during a pandemic. First of all, there's often a lack of coordinated efforts. People are throwing lifeboats out and therefore feel that there's not sufficient time to conduct properly controlled, randomized controlled trials. And we'll see the folly in that. We recognize that there are challenges in getting access to funds immediately to develop these trials, get them running, and get them out the front door. We recognize that there can be delays in trial approval and certainly execution related to difficulties in accessing research personnel, which may need to be redeployed, and certainly who are less than enthusiastic in working in an environment where they may be in contact with COVID-positive patients. We also recognize that in patients who can't provide their own informed consent, that very often access to substitute decision makers, for example, and family members can be challenged in an environment where we don't allow family to come in to see their patients. And then we recognize that there are also barriers to collecting data, and therefore a need for pragmatic trials using readily available information, and as well, very important, perhaps less granular outcome measures requiring larger numbers of patients. And finally, and certainly in those environments where we're seeing a surge in clinical activity and loss of things like PPE, certainly people's attention does not really primarily rely on conducting clinical trials, but very often in trying to keep themselves safe and keep their patients from dying, and dealing with an incredible surge of patients coming in the front door, making sort of thoughtful approaches to investigation extremely challenging. So there's some nice reflective pieces, and I draw your attention to this article, which was published in the April 14th, the New England Journal of Medicine, which talked a little bit about perspective and drug evaluation during the current pandemic. And they really nicely reviewed some of the pitfalls of the where we currently are as it relates to this pandemic, predominantly those related to open label studies, which can certainly lead to erosion of trust, and also has implications perhaps also when we're using off-label use or drugs which would normally be used for a certain indication, when we're seeing drug shortages, particularly things like hydroxychloroquine in patients who use it for inflammatory or autoimmune conditions, when we're suddenly using large numbers of these medications, essentially distraction of those treatments away from those patients who need it, and where there's proven efficacy to the instance where we're using it with unproven benefit or even safety. And so what I'll do is I'll go a little bit back from where we were in the past, and many of us, including myself and many of you on the line, certainly lived through the SARS episode and some of the hotspots across this country. And we recognized that there was a lot of interest in doing clinical trials, and this was a nice summary of the clinical trials which were done during that time. Systematic review published on Open Access Journal PLOS Medicine, and they looked at 54 treatment studies, 15 of which were in vitro studies, and there were 3 ARDS trials. And many of these, unfortunately, were not randomized controlled trials or used any form of comparator. They were often open label, and they identified 26 studies of ribavirin, which were labeled as inconclusive, and importantly, 4 actually showed harm. And then there were other studies, convalescent plasma, something we're looking at now, or IVIG, 3 of interferon type 1, and we're looking at that again for this current pandemic, and 2 lopinavir or tenofovir, protease inhibitors, which are currently also being looked at in this pandemic, and all of these were inconclusive. And of course, if all else fails, we use steroids, and there are several studies in the SARS epidemic were predominantly inconclusive, and there were 4 at least that demonstrated harm. And a very sobering moment when you reflect back that we learned absolutely nothing and are not in a position right now to address yet another coronavirus pandemic. I like this paper. It's again looking back at H1N1 back in 2009, moving from SARS. And they coined the phrase at the beginning of this review, a crisis is a terrible thing to waste. And in this study, they reflected on the use of perimavir, which is a neuraminidase inhibitor like oseltamivir, but given parenterally. And there was an emergency release under the EUA from the Federal Food and Drug Administration of the US, which allowed access to this medication. And there were over 1,000 access to drug. Essentially, you could call in and get the drug within 24 hours. It was a monumental task across the country. Unfortunately, there was no prospective registry for this, and there were simply surveys after the fact. And a significant percentage of patients were treated and not followed, and there was no information available. And as a result, the amount of data available to evaluate any clinical efficacy or even harm was completely lost, and therefore no further ahead. And of course, here we are now. If you just turn to things like hydroxychloroquine, azithromycin, essentially the rationale for using hydroxychloroquine is that it's an inhibitor of heme polymerase, and as a result, they have antiviral activity because of alkalinization of the phagosome, which essentially inhibits viral replication. And as a result, there was some rationale for its use, and there was some early interest. You can see towards February, and then in March, late March, there was a paper out of France, which was published, and then a few other unpublished papers which were emerging, as well as a few notable individuals who were promoting this, including our friend to the south, perhaps somewhat a conflict of interest, but you can see that there was a significant uptick in certainly social media, and we saw ourselves at our own hospital, there was a splurge on requests for hydroxychloroquine and azithromycin as prophylaxis from several healthcare professionals as well as medical students, essentially writing prescriptions for themselves to access this medication from different pharmacies. We chose at our place to not allow any off-label use unless it is used in the context of a clinical trial, and therefore shut our doors to any unauthorized or off-label use of any of these medications. If you look at hydroxychloroquine, azithromycin is the one perhaps earliest at the door. It's actually easy to acquire. Unfortunately, all the trials today have been essentially non-blinded trials. 5 of them have been published, only 2 of them in journals, 3 of them sort of online. And the long and short of it is that none of the trials demonstrate any efficacy, and there are some harm signals in some of the trials, particularly those with higher doses. Both those drugs, hydroxychloroquine and azithromycin, being drugs which can affect the QT interval, and given the existing cardiac sequelae of this infection, does raise concerns. We also have seen a recent publication which amazed everybody, that this was published in the New England Journal of Medicine, but it is a newspaper and has to sell issues, so it certainly was something that was popular at the time, and looked at the compassionate use of remdesivir in COVID-19, and this was essentially through an emergency access program from the company, and evaluated a 10-day course consisting of 200 milligrams on day 1, followed by 100 milligrams for day 9. And you can see essentially that 53 patients were enrolled, some of which who were receiving invasive mechanical support or ventilatory support, and some are receiving non-invasive support. This is kind of a telling slide, I guess, and I guess again, in context, it's difficult to sort out because there was no comparator. But if you look at a few things, if you just draw your attention to these 2 areas, essentially, if you look invasive, non-invasive, low flow oxygen, ambient air at the time of receiving the drug, this is the one in the ICU certainly we're more used to seeing. And you can see those who were receiving invasive ventilation where most of the deaths occurred. You can see that the mortality rate of 18% is generally a little bit lower than what we would see from most of the other cohort studies, where it would be 25 to 30%. Again, this is a select group of patients who were received this medication. Of interest, however, were the number of patients who were discharged from hospital, which seems fairly optimistic, I would say, based on what we're seeing right now, and so is perhaps a signal of interest in that these number of patients who are invasively mechanically ventilated in the intensive care unit would be discharged before day 28 as part of this clinical open label access. There are some limitations here, and if you look at all 53 patients which were evaluated in the study, and these represent invasive mechanical ventilation in the red, you can see some of these are dark red, and those are patients who are receiving extracorporeal support, and these in the yellow are non-invasive. A few things come out of this. First, and these bars represent a full course of therapy when they finish, 10 days of therapy. You can see that many of the patients did not receive a full course of therapy. What you also don't see here is that many patients entered the study at different times. And so on average, the number of people who received drug while on mechanical ventilation were about 2 days being intubated. However, up to 2 weeks prior to their, or rather after their symptoms, before they started to receive medication. And as a result, there's a potential for lead time bias here, which may have translated into the more rapid improvement if they were sick much further out before they received drug. It's not entirely clear as to the tempo of their disease. You can see the deaths are in the black here, and you can see the discharges with the open triangles. What you also see is that many patients have not really been followed fully to day 28. You can also see that there are many patients who have missing data as demonstrated by these hashed bars. And unfortunately, the end result is it really leaves us no further ahead. Essentially, something was given and then something happened, but we really don't know whether this actually affected outcome. And as Niall will tell you, in our own intensive care unit, we would have similar results to this, with the number of patients coming off ECMO, being extubated, sent to the floor, and improving. We would have very similar results without using any specific therapy. But recognizing that we perhaps see a very biased group of patients who are referred to our site for ECMO support and therefore may have less more comorbidities and have been slightly younger. I'll just quickly go through some of the other trials in the interest of time. There are trials which are currently being evaluated, and one of the other areas are on the protease inhibitors, lopinavir or ritonavir, which is used in HIV. This was a trial which was recently published after some open label exposure cohort studies. This was an open label trial with randomization, and the comparator was standard of care, and looked at essentially 200 patients with pneumonia. And as you can see, unfortunately, there was no significant difference if you look at clinical improvement rate between the intervention and the open label, or rather the comparator with standard care. And similarly, discouragingly, viral load really did not change between the two treatment arms either. Currently in Canada, there is an interest, as there has been for other conditions, in using convalescent plasma. Our first speaker alluded to the fact that there's an increase in IgG and IgM in the convalescent phase of this infection, and this is capitalized upon that notion. Certainly using specific, or rather non-specific IgG or IG plasma, which is represents convalescent serum for CMV, HSV, and RSV has been evaluated in other viral infections, so potentially this has some merit, although I must say the data for use in other viral infections is often quite equivocal. But currently in Canada, there is a planned study, 1,200 patients with 2-to-1 randomization. It is not a blinded trial, and the comparator, again, is standard of care with some very simple outcome measures, which are either intubation or death at 30 days. So looking back, or looking more broadly, we certainly recognize that there's a need to do these studies. And as a result, there are global initiatives to evaluate our various pharmacotherapies in a very thoughtful, systematic way, particularly in resource-limited settings. One of the trials which was put into place, which was planned quite early on, was the REMAP-CAP study, which is a factorial, rather a adaptive trial design. Adaptive trial design essentially evaluates several therapies at once and uses more of an iterative process of guiding ongoing conduct of the trial, and differs from the usual way we evaluate treatments, where we compare different treatments, look at outcomes before moving on to another form of therapy before we go on to another therapy. And this kind of puts them on top of each other, where we evaluate the different strategies simultaneously. We can essentially bias the trial either at the time of randomization or we can start to determine through interim analyses winners and losers and either drop them off, either drop off a dose or not, or drop off the strategy altogether and quickly plunk in another strategy, or focus on the winners if there are any are found. And this allows perhaps for more rapid revision of the study, enriching the study, and hopefully developing or at least finding treatments which are potentially efficacious. There are some problems with doing this, but they can be overcome if they're carefully conducted. And so the current one, that is the this one that I'm talking about here, the REMAP CAP study, is looking at different strategies, including lopinavir or tenavir, as well as looking at hydroxychloroquine, looking at interferon-1 alpha, and as well as looking at interleukin-1 receptor antagonism, and also IL-6 antagonism using things like tocilizumab. And so there are several types of therapies which are being evaluated on an ongoing basis, and essentially some sites are involved in a couple of them, and other sites are involved or more than one of them through this sort of adaptive trial design. There's another trial which is looking again at adaptive trial design, looking at different treatments, again looking at the protease inhibitors, looking at remdesivir and combined or not with interferon beta, and also exploring the role of hydroxychloroquine without azithromycin, and this is known as the Solidarity trial, and many of us are involved in that current study as well as the REMAP CAP study. So how do you keep ahead of this? Well, there are several things available. You can look at keeping up with the literature. You can go to several websites to sort out where the current trials are and where the therapies are. This is the Infectious Disease Data Observatory, which is a nice reference source for ongoing trials as they move through. The Cochrane Group is developing a rapid review of systematic reviews of ongoing clinical trials, which should also provide a valuable resource. We also recognize that there are certainly other resources. The Surviving Sepsis campaign is a very nice, pragmatic approach to the patient in front of you with different recommendations. Some of them Niall went over related to mechanical ventilation, but also other forms of support, as well as providing adequate safety and provision of care for health teams. We also recognize that the Cochrane Library also has an excellent series of articles or systematic reviews as they relate to critical care. And so finally, hopefully I provided you with a reasonable review of the current state as it relates to clinical trials facing us in this pandemic, some of the shortcomings as it relates to the previous pandemics, and trying to sort out what might work and what doesn't, and then some of the strategies which are currently in place, hopefully to allow us to see this as an opportunity where we're able to actually move forward and learn something this time and not be lost in the dark. I'll take any questions. Thanks.
Thank you, Dr. Granton. I realize we're running a bit tight for time. If it's okay with the speakers, we'll run a few minutes late because we have some questions that I think are interesting, and if we could get them addressed, that would be great. Before we start with the questions, though, I'd just like to thank the CAS office for organizing this yet again, the speakers for providing excellent talks, and the CAS members for actually providing the financial support to allow this to go forward. On that note, I'm going to start with Dr. Hoang. I've got a lot of questions about testing, and specifically point of care tests. I think what people would like to see is whether or not there's going to be a rapid point of care test that when we get a patient coming to the operating room who may not even have symptoms, do you see that we're going to get a test where we can just test them and know within 20, 30 minutes they're negative and then ditch the PPE? Or are we going to struggle with that? I just would like your thoughts on that.
That's a highly controversial and challenging question to answer. So you know, again, there's multiple components in the interpretation of a negative result. Going back to, you know, regardless of the operator, where is the patient in the course of illness, what is the specimen type, and then of course, very importantly, the performance of the test. So the rapid test that you're referring to is probably the Spartan cube that was hit the media last weekend. That caused a huge frenzy because, you know, as the microbiology community, we have not been well informed of its performance. There's been no beta tests. We really don't know how it performs. Apparently, it managed to get Health Canada approval for collecting a sample using a swab that's really never been used in the diagnostic labs before for infectious disease purposes, with a 5-minute transfer time from collection to immersing the swab within the cartridge of the device. In order for the test to run, the site needs to have access to frozen reagents. The reagents needs to be kept in a cold chain, a frozen state, and removed shortly prior to use. So there's a lot of technical components that is not well publicized in this particular product. So we had a nationwide teleconference regarding this, and there's a general sense of hesitancy. However, because of its claim to rapid turnaround time, there are a number of sites that are putting efforts into doing our own analytical evaluation to determine its performance compared to our gold standard of qPCR and other tests that we're comfortable with. So if this test is good and is able to deliver based on the claims that it's made, I think there is certainly a value. However, it also depends on the prevalence of the disease. So if there's a very low prevalence in the community, you know, are we comfortable to say that a negative result is going to provide a true evidence of the patient not having COVID? I would think so if the prevalence is low. If the prevalence is high, then I think our healthcare professionals are probably safer with just assuming that every patient is positive. So it really depends on where we are on that curve in making those decisions. Sorry, I hope that answers the question.
Okay, so let me follow up because we keep hearing high and low prevalence. Can I put you on the hot seat and give us a number of what you would call a high and low prevalence for this test?
Right, so I'm not going to be able to give you a number, but in BC at least, you know, we're struggling with trying to figure out what is the true prevalence of our population. And I don't, based on the data that we're seeing, I don't think our prevalence is going to be higher than 10%. But again, with reports on asymptomatic cases and potential asymptomatic transmission, you know, if our prevalence is 40 to 50% in the population, you know, we certainly aren't seeing that, and we're not aware of that. And the only way to confirm that would be by serology. So let's say you have a long-term care facility and there's an outbreak in that long-term care facility. And patients from that facility is being delivered to your center for care. I would assume that those patients are all positive. I wouldn't bother with testing and just make sure that, you know, everybody is on full PPE as recommended. Let's say that, you know, we've leveled off the curve, you know, there's significantly reduced number of cases in the outbreaks in the community and cases in the healthcare facilities. You know, maybe you're looking at, again, it depends on the population, but, you know, 1% prevalence, 5% prevalence in measured populations, then it may be valuable, particularly if there's potential risk factors and that sort of returning traveler from abroad, or contact to a known positive, that sort of stuff. But as a routine, all-inclusive screening for all patients, I'm not clear yet that the performance of these assays would deem them valuable for the OR bedside to screen out negative and positive cases.
Okay, thank you. The next question for Dr. Ferguson, and that is around your COVID-19 patient who let's just say for argument's sake, is on 5 liters mask and is getting more short of breath. Would you go to intubation or high flow nasal cannula, non-invasive mask to start with, and what would sort of affect your decision making?
So great question. I think the key is to get a sense of what the patient's trajectory is. Are they on their 5 liters of oxygen now and they were on room air half an hour ago, and in 20 minutes they may need even more oxygen, and how much work of breathing they're doing. So that can be challenging to judge. It's not just about counting respiratory rate, but it's actually sort of looking and examining the patient and trying to gauge their efforts, because the reasons for intubation are either profound hypoxemia that's not responsive to non-invasive efforts, or very high work of breathing that you're worried that the patient's either going to tire out or that they're causing self-inflicted lung injury with that. We're not using non-invasive ventilation, because non-invasive ventilation is not a good treatment for hypoxic respiratory failure in general, and also because of concerns with aerosol generating procedures. But I think so I would look at this patient and say, well, if they're still hypoxemic, I would turn up the oxygen using either high flow nasal oxygen or a TAVISH mask, a non-rebreather mask with a filter built into it, and then look and see if the patient's fine in terms of their work of breathing, and I'm able to get the saturation up with that strategy, then great. But those patients are extremely, potentially fragile, and I think need to be monitored. So they should be admitted to some sort of an intensive care area, potentially a level 2 unit where they could have close observation, because if they're worsening, you want to step in and intervene before having to run a protected code blue on that patient. And I think people have been saying, oh, we don't need ventilators, we'll just put people on high flow nasal cannula, maybe even get them prone. Great. I think that may get some patients through, but again, they need to be watched like a hawk. And I think the consequences of an unnecessary slightly early intubation are less than the consequences of a late or a not soon enough intubation.
Great, thanks. Another question, and I'm going to put this one to Dr. Granton, and this is about other potential management strategies for hypoxemic failure with normal lung compliance. And I guess the concern is shunting, whether or not they've got thromboembolic disease associated with this. Do you have any management caveats, strategies for those patients outside of the regular oxygenation support?
Right. To me, and I think it's a very interesting group. And again, I think it illustrates the heterogeneity of this condition, and whether they migrate through one type into another, it's hard to know. We've certainly seen that, but clearly some patients have, as Neil said, and others have described, more classic ARDS pattern. Others have what seems to be just predominantly intrapulmonary shunt without much burden of airspace disease. And it would appear to be related to some abnormalities in the distribution of blood flow for whatever reason. So thromboembolism certainly is a possibility. And when we see a chest X-ray like that in a profoundly hypoxemic patient, we do wonder if there is a role of macroscopic thromboembolic disease. And so it's always a bit of a challenge to move these patients to a scanner for multiple reasons. But we try to do that, or at the very least, we may do a leg study. I know people are sending up D-dimers and trying to sort out whether they may have a thrombotic potential and having a low threshold for anticoagulating them. The other option is, the other consideration certainly is an intracardiac shunt. So be mindful of the possibility of intracardiac shunt through a patent foraminal valley, and so doing an echo with bubble study to exclude that as a possibility should also be considered. It does raise the notion, in addition to anticoagulating, if you do see macroscopic thromboembolic disease, or there will be trials of using heparin in this disease, and I would probably reserve the decision to anticoagulate in the absence of thrombosis to those trials. The other option, of course, is inhaled pulmonary vasodilators, and as we know from ARDS literature, there's no benefit on outcomes using inhaled nitric oxide. We do, however, in somebody who is failing, we have seen responses in our own center of using inhaled nitric oxide, and there's certain reports out there, so we do try it as an intervention. There are studies planned, and a couple currently underway looking at fairly high doses of inhaled nitric oxide is actually a treatment for COVID-19 or SARS-CoV-2 virus. There is some data to suggest that nitric oxide has antibacterial and potential antiviral properties, and so those trials are starting and some are ongoing. So,
great, thank you. I'm going to finish off with one last question, Dr. Hoang. Again, back to you. An interesting question. Do you think that once you have the COVID-19 infection, you're immune for life, or do you think that patients are going to be at risk of reinfection?
I think that's $1 million question right now. Good question. It's hard to say. I think our references are the human strains of coronavirus that's associated with a common cold. We do know that people can get multiple exposure and repeat infection from the same strain of the common human adapted coronavirus. There's been reports of reinfection or reactivation in South Korea. Again, we don't know the details of those cases. Whether there's been genomics to compare and type those strains. And the clinical course of these cases. So I think that really is an important a determination that still needs to be assessed and will define how vaccine will be implemented and whether this is going to be a one-time vaccine or an annual vaccine similar to the flu vaccine.
Great. Well, again, I'd like to take this opportunity to thank the speakers. This is an excellent session. And thank all the people who tuned in and who have stuck around an extra 10, 15 minutes for the questions. I think that shows there's a lot of interest in this area still. Again, everybody stay safe out there. All the best. Thank you very much. And just a reminder, our annual meeting is going virtual, and it will be Saturday, June 20th and Sunday, June 21st, 2020. Thank you all again. Have a nice weekend.